Hello and welcome to our first review of the lupus literature for 2024. We're going to be recording these podcasts for you every month, so you'll always be able to keep up to date with the latest literature and expert opinions. I'm Ed Vitale. I'm the chair of the Lupus Forum. I work at the University of Leeds in the UK, and I'm joined today by Professor Vibeke Strand, who's an adjunct clinical professor of immunology and rheumatology at the Stanford University School of Medicine in California. Welcome, Vibeke.
Thank you. Nice to be here.
So today we're going to review some key January publications that were selected for presentation in the Lupus Forum. And we'll jump straight into the first one, which I think I'll introduce this, but actually I think you know these data very well, don't you? Because this is about the efficacy and safety of telitacicept, which you and I discussed in our ACR podcast. So telitacicept is a newer molecule in the BAFF inhibition class, which we all know from the use of belimumab. And the idea here is that the BAFF is actually a slightly more complicated system because you've got BAFF and APRIL, two ligands that have a similar role, and they bind to three different receptors called BAFF receptor, TACI, and BCMA. And so the idea is that belimumab is neutralizing BAFF, but it's not neutralizing APRIL, and APRIL is more important for sort of later stage B cells. So the theory of telitacicept is this is a molecule that block both BAFF and APRIL, or BLyS and BAFF, same thing, and therefore more comprehensively block the system, get a better B cell blocking effect to be more effective. It's a molecule developed in China, and it's actually been quite extensively used in China, but here we're only seeing phase 2 data. So this study was an active lupus trial. It was an all lupus organs trial, so it wasn't specifically non-renal, and there are some renal patients in there, but more of them had skin, joints, immunology, general. Fully Chinese study, so all 100% of the patients were Chinese. Like most lupus studies, mostly women. SLEDAI needed to be 8, and in practice here it was like about 10 to 14, which is pretty typical for a lupus trial. 90% of patients had either a BioLeg A or a B, or thereabouts, meaning that a few actually didn't have an A or a B. And the main organs were immunology, skin about 80%, renal around 60%, MSK a bit lower than I think we normally see at around 39%. Standard of care, they could increase the steroids, no new immunosuppressants, fairly standard. There were 60 patients in each, or 62 to 63 patients in each of the 4 groups, 1 for placebo, and then 3 doses, 80, 160, 240. So that's pretty small for this kind of study because you get a lot of heterogeneity in lupus populations. And I did think the groups looked slightly unbalanced to me. But the main results were, as you see there on the screen, that an SRI-4 response was met in 33.9% on placebo, with significantly higher reported for 80 milligrams, 71%, 160 milligram dose, 68.3%, and the 240 milligram dose, the highest at 78.8%. So I think this is, as we've often said, these effect sizes seem large, and that makes you think, want to take a bit of a deeper dive into how it was done and what the data showed, doesn't it?
Well, Ed, I agree. We saw this study at ACR, and of course now it's published. It's quite positive. And you can see over on the right side of this slide also, the onset of effect is evident even at 4 weeks. And there's statistical significance for all of the doses, although there clearly is some benefit that's better with the 240. I wonder a bit whether this is because it's an Asian population, but it's difficult to know. And going through all the data, I think it's very interesting. One of the points about the trial that supports its positivity are changes in the biomarkers. And you can see here very nice changes in C3 and C4 levels that were actually fairly low in a majority of patients. And so it's, again, nice supportive data. Is a time to the first severe lupus flare. And this is nicely differentiating, arguing again for the 240 milligram dose being a better dose than the other two. Now, this study was done between 2016 and 2018. So it was finished quite some time ago. And I remember reviewing the data even before it was presented at ACR. I'm not sure why the delay in putting it out in the public domain. And I do know that they are planning or are in the midst of doing an international study. So it will be very interesting to see if this product behaves similarly in a much larger phase 3 study, which is, of course, what happens with our positive phase 2 trials. They move on to phase 3 with a much larger population that's much more different from phase 2, and you don't get the same results. And we've seen that repetitively. I think another point, of course, is that being a BLyS and APRIL inhibitor makes it a more effective type of therapy. And so one of the points is that a US company, Alpine Biosciences, has povetacicept, which is also a BLyS and APRIL inhibitor. And their data suggests that it's even more effective against APRIL than telitacicept, while still maintaining the benefit against BLyS. So we'll just have to see, but I think this has become a class of therapies now for us to pay attention to.
Mm-hmm. Yeah, I was wondering, like you say, about this is a slightly different type of lupus trial to most of the licensing studies we see, and does the fact that it was all done in one country have an effect on the results? And it maybe, I could imagine, so patients in China tend to get more severe lupus, but the way that standards of care may be different. I don't know exactly. And that might be one factor leading to bigger deltas and differences between treatment groups. We know from other big studies that we quite commonly see differences when the results are broken down according to different ancestries, and also according to different geographic locations, like the EMBRACE study of belimumab being quite a classic one. And so those things have quite large effects, which really makes me think I really want to see this effect replicated across a more demographically diverse population to know what's going on. Your point about the effect being seen as early as week 4 is interesting, actually, because that's quite surprising. But one thing about belimumab is it takes time to work, isn't it?
Well, part of that was a belimumab trial design,
right?
Because they really made it difficult to see a difference because there were changes allowed in the first 4 months
of course,
in background therapy.
Yeah.
So
yeah, that is a good point. So I guess it's promising, but we have to watch for the next trial results. Conclusion here.
Agreed. Yeah. Agreed.
Okay, should we go on to the next one?
So fatigue is a very big effect of lupus, and I think we're finally becoming a lot more cognizant of the magnitude of that effect. And so this is the LEAF study, which was a way of looking at patient-reported fatigue across a variety of components. And it's a very interesting study. So they started with the participants, of which there were 1,647 patients. And then they looked at those that had self-reported lupus and those that could not be included in the analysis, of course, were excluded. And then essentially they had a variety of inclusion criteria shown here, and they made sure patients were 18 or over. And essentially what they did was they administered a variety of patient-reported outcomes, a variety of instruments, and they used those to characterize the fatigue. So, for instance, there was a disease activity assessment by a numerical rating scale by the patients. There was HADS for depression. There was an insomnia severity index. And there was also PSS and IPAC. And then they looked at the fatigue by the FACET fatigue, also by a fatigue intensity NRS, and also by the MFI. And finally, they had the assessment of usefulness. Did the patients think that this was a useful set of instruments? Did it actually inform them of their fatigue, which I found very interesting. So the majority of these patients reported significant fatigue, 78.9%, which is consistent with what we know from what our patients tell us, but we haven't had good ways of, one, measuring it clinically or in trials, with the exception of the FACET fatigue. And we do know that fatigue has a huge impact on other PROs as well as health-related quality of life. And there is, of course, the vitality domain of the SF36, which often correlates quite closely with the FACET in clinical trials. So fatigue, interestingly, had a strong independent association with insomnia, and that's not a measure we've typically used, the insomnia severity index. And that may be a good thing to use, since we now have most of our patients completing these questionnaires at home, at their convenience, online. And so we're not sitting over them or standing over them while they're trying to hurry through the questionnaires. I think that the leaf was well accepted and considered helpful by the participants, because 93% of them said it was helpful and 92% said they would recommend it to another. And if we look at the fatigue comparisons, those huge numbers, 987 with fatigue, versus those without significant fatigue, 263, we see statistical differences in virtually every parameter except low physical activity, which I think is of interest. Disease activity, statistically significant. Pain, first. Anxiety, depression, and insomnia, as we talked about, and stress as well. And I think it tells us that we really do need to pay more attention to these questionnaires and finding ways to use them in our practice. Now, whether we should do such a large multi-dimensional assessment such as the LEAF every new patient or periodically in patients may be too much, but then again, it may be quite helpful, because apparently these patients found it very helpful to complete all these questionnaires, and it essentially helped them with their perceived stress as well as their sleep. And I think that that's really quite interesting. Ed?
Yeah. Yeah. So it's interesting your point that the patients felt that filling the questionnaire was of itself useful. I mean, in a way, I know patients sometimes find it quite annoying when I give them a lot of questionnaires, but then on the other hand, they also sometimes say, I've had that whole consultation, nobody ever asked me about what mattered to me. And so in that sense, questionnaires to actually capture are perhaps what people sometimes call the invisible symptoms, can help somebody to say, I've explained, I've expressed and documented the symptoms I'm having. In terms of the one thing I was thinking about, though, is that in my clinical practice, the thing about I recognize a lot of people tell me they have fatigue, but I find it very difficult to understand the reason for the fatigue in that particular person. But sometimes it is simply disease activity, and if I treat it, it might make a difference. But sometimes it's not. Sometimes it's some other problem or something related to lifestyle or something.
Sure.
And I find it,
Sure.
I struggle in clinic to understand that, and then therefore to know how to manage it.
Well, perhaps, if you looked into it a little bit more, you would recommend something different for depression versus insomnia.
Yeah.
or,
Okay.
reported stress versus one of these others. I do think disease activity plays a huge part in fatigue, for sure, because I think we do see that when disease activity goes down, fatigue is one of the first things that patients do note as being better.
Yeah.
And I don't think a lot of this is fibromyalgia. Yes, I know that they fill out the first and it says that they have fibromyalgia, but I think that that's just part of when you link your physical disease with the multi-variable symptoms that come along with lupus. How could you really not answer many of those questions in a similar fashion?
Absolutely agree. I found the same thing when we did lupus arthritis research, that how these tools to decide whether someone has also got fibromyalgia, it's hard for them to function well when someone has got an active arthritis due to another disease at the same time. So okay, so that one's interesting. And then we've got one more study to discuss, which is an initial paper from a study called Spock's, which is published by Laurent Arnaud et al. And Spock's is a very large observational study. So it's the SLE Prospective Observational Cohort Study. It's AstraZeneca sponsored. So this is about the burden of SLE in clinical practice, and in particular, according to interferon gene signature. So the idea is that from many of the drugs that are licensed for lupus, including anifrolumab that AstraZeneca make, but also others that are currently marketed or those in development, we often see some baseline variables that stratify who's going to get a better response. And common among these, well, so we know that for some, for example, belimumab, it was double-stranded DNA and complement. For most drugs, a higher SLEDAI score is associated with better efficacy of the drug. And for anifrolumab and some of the others, especially some of those in phase 2, the interferon gene signature has been associated with a better response. So that leads to the question of identifying, who are these people who have either a high SLEDAI or a high interferon gene signature? Is their natural history different from the patients with lower SLEDAI or lower interferon gene signature? And therefore, would that guide us into how to use one therapy or another? So what they did was they enrolled 823 patients in 135 centers across 8 different countries. And the patients were seen twice a year for up to 3 years. Most types of lupus could go in, although active lupus nephritis was excluded. So I think there are a number of analyses planned, but the paper we're looking at here is just the baseline data. And I think some of the important questions that come up will be answered when the follow-up are presented. So if you look in this paper, the main thing you see is quite descriptive results showing many characteristics of the patients in terms of demographics, time of disease onset, the organs affected, the immunosuppressants and biologics being used, the glucocorticoid use, flares, comorbidities, all of these different things, according to whether the SLEDAI was greater than 10 or lower than 10, or 10 or more, or lower than 10, or whether the interferon gene signature, using the same gene signature used in the anifrolumab trials, was high or low. And so for the SLEDAI, I think most of the results were ones that you might guess. So patients who had higher SLEDAI scores, younger age of onset. So yeah, we know that people with younger age onset lupus under about 28 or so at age of onset, you're going to get more severe disease. And they also had things like more flares and needing more therapies and steroids. That's not all that surprising, I suppose. For the interferon gene signature, there were some things we know quite well and some things that may be slightly surprising. So again, they were younger age of onset. Again, they were, in terms of ethnicity, so the coding they used not an ideal one. They said Asian, Black, white, and Latino ethnicity. So Asian and Black had mostly, the majority of those patients had high interferon gene signature, and interferon low patients were much more likely to be white. But I would really like to see those broken down into slightly more meaningful subgroups, to be honest. Trends to higher SLEDAI, but not significant. Then some things that the high interferon patients had less of. So the high interferon patients had less damage, they had less comorbidities like strokes, renal disease, metabolic syndrome, and they had less musculoskeletal disease, but more skin disease. So some of those, I generally associate interferon gene signature with being a bad thing, but there were some things actually that were worse in the interferon lows. Reasons for that? Well, maybe the interferon lows were simply they're older, they're going to have more comorbidities. Maybe. I think the relationship with MSK versus skin, interferons high have more skin, interferons low have more joint disease. I've seen that before in my own research, and I've seen it in a few studies. I think that's a real thing. That's something to do with the biology of the lupus. The interferon high patients were generally receiving more treatments overall, so more immunosuppressants, more biologics,
Yep.
and importantly, a lot more steroid. So right. I think this is telling us something about this population, but I think some of these things I'd be very interested to see how they evolve over time, because a lot of these differences we're seeing had arisen before enrollment into the study over the years, and understanding the causality and things is maybe a little bit complicated in some cases. What did you think about this?
Is there anything that isn't complicated in lupus?
Yeah.
Okay. I mean, I think that it characterized a population that we are already more or less recognizing. Again, it would be nice to really trust the biomarker of interferon gene signature, so we would know who we should expect a response with anifrolumab with.
Yeah.
But we didn't see that in the trials, and so we can't use that as a predictor. I think this study should help us characterize patient population, but we're almost beginning, like you said, to recognize who these patients are based on their clinical characteristics and how their disease activity progresses. So I think it's an interesting study. We'll learn more, as you said.
Yeah, I think, yeah, you're right. I mean, I often say, I did a lot of work with interferon gene signature, and I often started saying, I think I can guess a lot of people's interferon signature by what they look like with their lupus, their routine immunology, things like that, their demographics. I can often make a pretty good guess what it's going to be. I think interferon signature and response to anifrolumab is, again, complicated again, because on one hand, is it telling you what molecule's driving that disease, and therefore which would be more effective to block? But on the other hand, it could just be telling you who's got most active disease, better than the SLEDAI.
That's right.
The two people with a SLEDAI of 10 can have different disease activity. And the interferon signature might tell you that, and the higher one with the more genuine active disease is more likely to show a big response. And in that sense, it would stratify any drug, not just anifrolumab. So,
right.
I mean, the other thing I noticed from this was something, again, I saw it in my own research, which is, so what a long time ago, we did looked at a cohort, and I had the idea that high interferon signature would help you know the people who complained of worst quality of life. I thought they'll have interferon signature. It's flu-like stuff, isn't it? So they're going to complain of fatigue. They're going to complain, these sorts of symptoms. And I asked a research fellow to have a look at it, and she came back to me and she said, no, it's the other way around. The high interferon ones actually felt a bit better on a lot of quality of life measures. The interferon lows were the ones who felt worse. And I thought, are you sure you've got that right? And then I spoke to another group of investigators, and they said, oh yeah, we found the same thing. And then I was speaking to a statistician colleague, and she kind of made me think about it a different way, because she sort of said, well, how do you get into your clinic? And I sort of said, well, they usually have positive blood tests, you know, ANA, things like that. And yeah, that goes with interference signature as well. If you got one blood test or more. And she was like, so if you were negative for those blood tests, how would you get into your clinic? And I was like, well, you'd have to have much worse symptoms to get into the clinic if your bloods were normal than if they were abnormal. So in other words, it's how you get into the study, and it's not even recruitment, actually. It's just being in this clinic so you could be recruited.
It's yes, selection. Yeah,
Totally beyond my control. Totally beyond the
right.
person collecting the study, beyond the table one of characteristics. You know, there's an unseen effect that's used where the interference signature itself biases who's in the study. So yeah, I think that's so. Unpicking these effects in trials can be complex. But anyway, yes, I think we have to look for the longer term follow-up, but it helps. I mean, it just helps give you a picture, doesn't it, of the
very interesting.
the spectrum of lupus and the populations in whom we might use the new therapies that become licensed, and probably being resource we use for a long time. So that's all we've got time for today. Thank you for joining me, Vibeke. It's great to hear your thoughts on the latest developments in lupus management.
Thank you, Ed. It's always a pleasure.
And thank you, everyone, for listening. You can find the full slide decks for these 3 papers at lupus-forum.com. The Lupus Forum is free to access. All our content's free to download. Don't forget to register for updates on the Lupus Forum. You'll get email updates whenever new content is made available. And you can also follow us on Lupus Forum, all one word, on Twitter and on LinkedIn. Thanks again, and see you next time.